Welcome to the Pediatric Advanced Life Support chapter on bradyarrhythmias and tachyarrhythmias. Arrhythmias are caused by abnormalities in the electrical activity of the heart. Also known as cardiac dysrhythmia, they can be classified as bradyarrhythmia, tachyarrhythmias, or pulseless arrest. Bradyarrhythmias are the most common arrhythmias in children, and they usually present with low blood oxygen or hypoxemia, low blood pressure or hypotension, and a buildup of acid in the bloodstream or acidosis. Bradycardia is a heart rate that is slower than normal for the age of the child. Usually, anything under 60 beats per minute is indicative of bradycardia, and immediate CPR should be initiated. Some common signs of bradycardia include poor end oxygen perfusion, shock with hypotension, sudden collapse, and altered consciousness. Common symptoms of bradycardia include change in level of consciousness, dizziness, lightheadedness, and fatigue or fainting. When considering bradyarrhythmias in children, there are 5 types that may be observed. The first type of bradyarrhythmia is sinus node arrest or sick sinus syndrome. This is associated with abnormal heart rhythms because of the malfunction of the sinus node. These may include atrial, junctional, and idioventricular escape rhythms. The second type is sinus bradycardia, which originates in the SA node with a low rate of fewer than 60 heartbeats per minute. It develops because of decreased metabolic demand and can be caused by hypoxia, poisoning, hypoglycemia, or hypothyroidism. The third type of bradycardia is first-degree AV block. This is where the PR interval is prolonged at more than 0.2 seconds, and impulses from atria to ventricles through the AV node are delayed. There are usually no symptoms associated with first-degree AV block that would signal an emergency situation. The next type is called second-degree AV block, which is divided into type 1 or Mobitz 1, and type 2 or Mobitz 2. The second-degree AV block type 1 is when the PR intervals are prolonged, the RR intervals are shortened, and finally, 1 beat drops. Dizziness may be a symptom, but symptoms are usually not observed. On the other hand, type 2 is when there is no change in the PR interval, but a beat will drop randomly. Symptoms may include an irregular heartbeat, lightheadedness, or fainting. The fifth and final type of bradycardia is third-degree AV block. This is a complete heart block where the P wave and the QRS complexes are not connected. When this condition is present, the impulse conducted in the atrium does not progress to the ventricles, and there is no communication between the atrium and the ventricles. Symptoms may include fatigue, lightheadedness, or fainting. Now let's look at the management of bradyarrhythmias in children. Proper care includes handling heart rate and respiratory distress or failure. As soon as you recognize a child is bradycardiac, you should immediately activate the EMS and conduct the ABC assessment by opening and supporting the child's airway, giving oxygen and or ventilation if necessary, and starting chest compressions with 100 compressions per minute at a cycle of 30 compressions and 2 rescue breaths. Next, attach a defibrillator for children over 1 year old and obtain a 12-lead ECG. Then obtain vascular access and run lab tests to get more information on the child's status. If bradycardia is still persistent, then continue performing CPR on the child. After 1 cycle of CPR, administer the following doses of medications to the child. Epinephrine via IV or IO access at 0.01 milligrams per kilograms and repeat every 3 to 5 minutes. Atropine at a dose of 0.02 milligrams per kilograms if there is increased vagal tone or primary AV block. Continue the process until the child's rhythm is back to normal. Consider the H's and T's, which are 10 reversible conditions that may have affected the child and consider cardiac pacing as treatment. This concludes our first video on bradyarrhythmias and tachyarrhythmias. Please proceed to the next video to learn more.